Hi and welcome, Maryville community and esteemed faculty. I am Marla Dressler Myers, and this is my scholarly project, Depression Management Quality Improvement for Home Health. My committee members included Maryville faculty, my chair, Dr. Maria Snell, and Dr. Rita Wunderlich, members from the targeted home health agency, Penn Highlands Community Nurses, Inc., included Christian Camuso, the operations manager, and Kayleen Porter, the performance improvement manager. With depression being a common mental health problem, it is essential to have practices in place to manage these symptoms. The depression care for patients at home, or the depression care path, has been specifically designed for implementation in home health agencies and therefore is the focus of this project. The aim of this project is to answer the question if implementation of the principles of the depression care path assists home health nurses to better screen and manage home health patients with depressive behavior. Adults and especially home health adult patients are among those most at risk for depression. Depression has an active link to suicide, decreased quality of life, and rehospitalization. Many home health agencies do not have a protocol for depression. Current guidelines that are in place need updating to meet the demands for depression care. The Depression Care Path provides a thorough depression assessment using both the Patient Health Questionnaire 2 and the Patient Health Questionnaire 9 scales and takes overall health factors into account. This protocol has evidence supporting its use to increase depression support and subsequently reduce hospitalizations. The Depression Care Path also can answer the United States Preventative Services Task Force recommendations for depression screening for all adult patients. The Depression Care Path principles offer solutions for adult home health patients as home health nurses develop unique, trusting personal relationships with these at-risk patients. Using the Depression Care Path capitalizes on the relationship and has been shown to better equip the home health nurse with increased depression confidence, better provisions for depression management, and to fill gaps in a holistic approach to care. Depression is among the most common mental illness in the United States, where it is estimated to be 17% in the general adult population. Patients with comorbidities have an even higher rate of about 25%. Depression has been a factor in rehospitalization and inpatient psychiatric admissions related to the risks associated with ineffective health maintenance, powerlessness, and chronic low self-esteem, just to name a few. The absence of routine screenings has been linked to the identification of only 2% of depressive patients. Depression has a high cost to healthcare, where it is estimated to be about $200 billion annually. Proper depression management decreases mortality, increases identification, and decreases cost burdens. The nursing discipline has a unique role in healthcare and mental health. They serve on the forefront of identifying and assisting those with depression. Their close relationships with patients help to break down barriers and stigmas to get these depressed patients the care management they need. Updating depression practices and educating nurses can help home health nurses better coordinate and manage care. Early identification of depression can lead to better outcomes. These include decreased rehospitalization, better overall health and well-being. Managing depression can readily be integrated into practice using the depression care path, building on processes that have already been in place within the home health agency. Medicare guidelines track depression management in home health, but do not specify how to manage these identified patients. The depression care path can help alleviate the process through simplification. During literature review, benefits were found with management of depression, which is the basis of the depression care path, where healthcare professionals have a role in identifying and developing strategies of care for patients with depression. The current guidelines for home health includes those for Medicare that do not reflect the current evidence. Therefore, the depression care path was ideal for this project. This evidence, coupled with the need for knowledge enhancements, makes updating practices a priority issue in the home health agency. Knowledge enhancement for home health nurses can assist competency, decrease stigma, assist identification and intervention to those who need it. Lastly, there's a need to alleviate symptoms to assist with better outcomes for patients. Depression affects much of the patient's overall health. The patient's mood affects their ability to care for themselves. Their depressive symptoms need individualized treatment, and the depression care path provides this through a decision tree based on the severity of their symptoms. Much research supports that depression remains prevalent and goes underreported. Recognition and management are essential to the nursing discipline because of their ability to establish therapeutic alliance and their frequency of care and assessment of these patients. Specifically targeted in this project was home health nurses who serve patients that are homebound, who are potentially isolated and lack access to care. Integration of depression care management would better serve these roles and help them to provide better care. Depression care path has been proven to be successful in the home health setting to assist nurses and break through stigmas and increase the quality of depression care. The theoretical framework for this project is person-centered nursing. This framework has 4 different components and impacted the project in many ways. First is how the nurse already is, or the prerequisites of the nurse or their current depression knowledge. By increasing the competency of the home health nurse, the patient's depression care will be directly impacted. The next is the environment that care is provided through the employment and education of the depression care path. The environmental element also works to create a place where the patient will be supported with their struggles. The patient-centered focus would be the intervening as appropriate to give that patient the individualized care that they need based on the severity of their symptoms. Also, this focus works by allowing the patient for input on what works best for them and considering their lifestyles. And lastly is the component of outcomes. The results of this project are based on the patient's well-being measured by the proper practices followed by the home health nurse and monitoring the patient health questionnaire scores after the employment of the updated interventional care to reflect the current evidence to support staff and subsequently the home health nurse or the home health patients. The methodology of this project was a quantitative exploratory design. A retrospective chart review occurred 1 month prior and then compared to 1 to 3 months after implementation of the depression care path. Depressive symptoms were managed according to the scores of the patient health questionnaires as appropriate. The principles of this protocol were embedded into customizable models in the electronic medical records, and the patient health questionnaire 2 and 9 were employed to identify the severity of symptoms and extracted for use in this project. 201 charts were reviewed and met inclusion criteria for this project. This project did not need recruitment as it was a retrospective chart review of electronic medical records or EMRs of adult home health patients managed by the depression care path at a home health agency located in the Northeast region of the United States. All genders were encompassed in the data collection, and data collection commenced after IRB approval had been obtained from Maryville University. Charts were selected based on the EMR schedules for home health nurses included into the pilot group for this project. Access was granted to the EMRs not regularly used for work purposes and terminated after completion. Each start of care and resumption of care visit were reviewed, as these were comprehensive assessments and a sequential inclusion-exclusion process occurred. The abstracted data was recorded and coded to represent the chosen variables and constitute the minimum necessary data to accomplish the goals of the project, and no protected health information was recorded. The sequence for inclusion was that the patient was screened and managed according to the depression care path. The EMRs were then reviewed to ensure that the patient was 18 years or older, had follow-up visits, and that they were screened by a home health nurse included in the pilot group. Other information included if the patient was prescribed an antidepressant, proper communication was maintained, depression management interventions and education was provided, the patient health questionnaire scores both pre and post implementation, any hospitalizations that occurred, and if the depression discharge summary was properly used. Exclusion was considered by age less than 18 years, lack of documentation of the components of the depression care path, lack of follow-up visits, or if the home health nurse was not included in the pilot group or did not receive proper education of the practice. Data collection concluded after the goal of 150 charts were reviewed post-implementation, and no charts were included if the patient was seen by the author of this project. A few data collection instruments were employed in this project, as the depression care path follows a decision tree and comprehensively manages depressive symptoms. First was the standardized patient health questionnaire 2 screening tool, which has 2 critical questions according to the diagnostic criteria of major depressive disorder in the DSM-5. The screening occurred at start of care, resumption of care, and as needed, depending on if depression was suspected. Based on the initial patient health questionnaire 2 scores, care is then escalated or managed accordingly. The patient health questionnaire 9 screening is only conducted if the patient health questionnaire 2 score is 3 points or higher to accommodate feasibility within the home health agency, since this was their running cutoff score already in place. The data collection tool incorporated each component of the depression care path and then coded for ease of data analysis. You can see here the coding as it was represented numerically. The sample included a comparison group and a research group, where over 99% were Caucasian and 0.6% were Hispanic. The mean age was 72 years, 115 females and 86 males met inclusion criteria for this project. All EMRs in the research group were screened using the patient health questionnaire 2, and 18 were further screened using the patient health questionnaire 9. 60 of the subjects were on antidepressants at the time of data collection. The data analysis for the information attained in this project included the use of systems and different statistical tests. Both SPSS and Microsoft Excel were used for data analysis, as the data collection sheet was a Microsoft Excel workbook sheet, and Microsoft Excel was utilized to the extent of its data analysis for descriptive statistics and for data frequencies. SPSS was then used for the Wilcoxon to identify relationships between pre and post patient health questionnaire scores. The Wilcoxon signed ranks test was utilized as the paired measurements greatly exceeded 5. There were 2 paired measurements, pre-test and post-test scores of both the patient health questionnaires. A 95% confidence interval was used to reject the null hypothesis when running this test. The Wilcoxon signed ranks test indicated that the post-test ranks of the Patient Health Questionnaire 2 scores were significantly lower than the pretest ranks, where Z equals negative 3.6. However, the Wilcoxon signed rank test indicated that the Patient Health Questionnaire 9 scores did not show statistical significance, where Z only equaled negative 1.731. An increase in sampling size may warrant statistical relevance in future studies, as more is needed to detect change in the Patient Health Questionnaire 9 scores. Of the 18 subjects that were further managed with depression using the Patient Health Questionnaire 9, 85% of them had proper communication and education documented in the EMR. Approximately 99.9 had proper interventions added to the care plans. 77% had an appropriate summary given to their primary care provider upon discharge. 8% had been hospitalized for worsening conditioning during the data collection period, none of which were the direct result of deteriorating depression, according to the EMRs. Overall, the scores in the Patient Health Questionnaire 2 had remained the same at 85%, where 10% had improved and 5% declined. Of the Patient Health Questionnaire 9, however, 1% remained the same, 9% had improved, and 3% had declined. Limitations may have impacted the results of this project, including bias and imperfections in design, measurement, and analysis. Limitations existed on the availability of depressed patients during the collection period. Theoretical limitations existed where individual factors of the depression care path were not easily translated from the charts for review. These limitations included the rehospitalizations, specific interventions, education provided, and proper communication. It is also unclear when antidepressants were started and their effects on the patient's depressive symptoms. Bias was considered influential as assumptions were made when charting definitions were unclear. Measurements of the variable did not include feedback of the home health nurses about their comfort level with depression care path, which may have influenced their ability to assist patients. Many nurses included in the pilot group consistently implemented the principles of the depression management. However, when the patient was in the care of a nurse not in the pilot group, essential factors were left out. This omission caused the chart to be excluded despite follow-up teaching to the nurses for possible inclusion into the pilot group. This project has generalizability to the home health adult population, as the project demonstrated significance when using the Patient Health Questionnaire 2 with the retrospective chart review of 201 charts. In addition, the results of this project can be sustained as the home health nurses are continually assessing patients. During these assessments, it is feasible to continue to ask these patients about their depressive symptoms using the Patient Health Questionnaires as applicable. Limitations were minimized, first by including patients with high Patient Health Questionnaire scores to the maximum potential if the depression care path wasn't evidence of being used properly. Second, charting gaps and bias were minimized as nurses were asked to clarify to the best of their ability given the retrospective nature of this project. Third, the nature of home health reduced the ability of this project to pinpoint the initiation of antidepressants, as patients are typically started on these medications from outside sources. These impacted the project first by a lack of depressed patients being included into this project, and subsequently the significance of the Patient Health Questionnaire 9 was not determined. Second, charting gaps also made it difficult to discern whether the principles of the depression care path were sequentially utilized. In addition, antidepressants were a factor in almost half of the research group, and without the date of initiation, their use may have influenced the scores of the Patient Health Questionnaire scores. Finally, the need for nurses to clarify steps of the depression care path impacted the future feasibility of the project, as compliance may be of concern. There are some differences in what was observed and what was expected in the outcomes of this project. Based on the frequencies of the descriptive statistics used, it was expected to have shown that the Patient Health Questionnaire 9 was significantly beneficial to patients with depressive symptoms, as generally the scores had improved. However, the inferential statistics showed that this might have been by chance, as the results of the Wilcoxons were not significant. This lack of evidence is likely related to the smaller sample size of patients with depressive symptoms. However, the initial step of screening using the Patient Health Questionnaire 2 seems to have been helpful, and there was substantial evidence that this was not by chance and that the scores had improved. It may have been helpful to have systems in place before implementing the depression care path to increase the feasibility at each step within the EMR, to minimize omissions and for more usable data going forward, and to provide clarity. The depression care path can assist home health nurses and other healthcare professionals in managing the care of patients with depressive symptoms, as it can also increase the number of patients being screened for depression using the principles of this protocol. Nurses are among those who frequently assess patients and can assist in early identification and intervention when managing depression. Nurses can fill gaps in access to care by interpreting scores, planning, implementing, and evaluating the scores to determine the direction of care using the depression care path as a guide. Healthcare policy should incorporate techniques to manage care, as they can incorporate these questionnaires to determine the need for further screening and subsequent intervention. With the depression care path, the depressive symptoms can be managed and provide better outcomes to patients by providing quality interventions and subsequent decreasing of depressive symptoms, as the depression care path can remedy a general lack of awareness and lack of early intervention for depression. This project found that with the use of the depression care path, depression can be better managed. However, the following steps should be included for future research, which incorporates more patients with depressive symptoms, as there was weak evidence demonstrating this in this project. These steps may include a comprehensive agency implementation about the same size as the targeted home health agency in this project, or a more extended data collection period. Based on these results, it is recommended to target patients with known depression as well for future studies across other settings to generalize results to depression across more healthcare settings. Future studies should also test a hypothesis about the perceptions of patients or nurses before and after implementation of the depression care path to guide practice further. The depression care path can impact practice by providing more screening, more feasibility, and subsequently decreasing the burden of depression. Please reach out and ask any questions at this time. And these are my references. Thank you for your time.